So I'm Lucy Brown, I'm the Deputy Director of the Florence Nightingale Foundation Academy, and I have the great pleasure of hosting today's webinar. This is the first in our Global Health series, and we're thrilled to be partnering with VET to provide this webinar today on diaspora healthcare workers, really valuing the contributions that these valuable nurses and midwives make to the UK, but also globally. I think it's fair to say the expertise of diaspora NHS staff is not widely recognised or valued as it should be. And we're hoping in this webinar that we can explore further and discuss ways in which the experiences and connections can really benefit both the UK's health system and global health as a whole. We're going to be hearing from some fantastic speakers this afternoon to share their variety of voices on these themes. And also we have Kit Chalmers here from VET, who'll be talking about experts in our midst, which is the latest report from VET, which is a really fantastic global health organisation that we're really honoured to work with. So we would love your discussion, your debate this afternoon. We really want to generate ideas and inspire action and champion inclusivity across the NHS and across the healthcare sector in the UK. So without further ado, I'm going to hand across to Kit. Thank you so much for joining us, Kit.
Thank you very much, Lucy, and thank you so much for making us this topic, at least the first of your global series. We feel very honoured. So I'm just going to introduce you to the background to this work which VET is doing, and I'm sure not all of you will be familiar with VET. So we are a global health organisation charity which supports specifically health partnerships between institutions in the UK, mostly hospitals, sometimes academic institutions, so universities or colleges, with counterparts in low and low middle income countries, particularly across Africa and Asia. And we do that through grant giving. We manage grants for various organisations, sometimes through direct programmes delivery and also through policy and advocacy, which is what this is part of really. And so Experts in Our Midst was our last major policy report, which was released in August 2021. I'll put a link to the paper in the chat afterwards. I can't multitask, I'm afraid. And its tagline is recognising the contribution NHS diaspora staff make to global health. And Lucy has already introduced, the reason we're looking at that, which is that we knew at VET, and we know that this is under-recognised and could be much better valued and much better use made of it for everyone's benefit. In the UK, I'm sure this will be no news to anyone at this meeting, the UK health system is hugely dependent on staff who have trained overseas, as well as those who may have a background in other countries. 15% of NHS England staff were trained overseas, with a big proportion of both nurses and doctors. As well as contributing hugely to the UK health system, those people who have moved here often contribute to global health systems as well. They do that through the sort of health partnerships we support, although not enough, as we found through this report, and also through what they bring to the NHS in terms of their skills, their cultural knowledge from different systems and cultures, and also very practically through remittances and various other supports that they send to their countries of heritage. And of course, if we didn't know before the pandemic, we certainly do know now that health systems are completely interdependent. So not just in terms of who's employed, but in terms of the health of our respective countries. So what we did for this work, I won't go into huge detail, but a sort of rapid literature review, so scoping of the literature to see what information we could find about diaspora contribution to global health. What we call at VET a public inquiry, which involves hosting some events where we hear from people with personal lived experience of this sort of issue and gather information in that way, and also through surveys of health partnerships, diaspora organisations, and some interviews. One thing we come up against again and again is how do you define diaspora? And I imagine there could be as many opinions on that in this webinar as there are people at it. So for the purposes of the report, this is how we defined it. So I'll just let you read that rather than me reading it out. Which I feel keeps diaspora as a broad definition really, which people can decide themselves whether they fit into. although looking at the background to this report, of course, we think very much about those people who have trained overseas, but many other people are included in that definition of diaspora. And this work took place between 2019 and 2021, and you don't need me to tell you what happened in the middle of that, which really brought to light even more the importance of this, the inequalities that are experienced, and again, that interdependence of health systems. So we know that the NHS benefits from global engagement generally. These are the sort of skills and benefits that the individuals in the system get when they take part in voluntary activities. So things like practical leadership skills, different knowledge, cultural competency, and then even bringing back innovations to their systems and also the cultural knowledge they've got. And we know that diaspora staff people, particularly who've worked in a different system, but also have knowledge of that, already have these things without having to take part in global health activities. We found through this report that the expertise, unsurprisingly, of diaspora NHS staff in global health is significantly underestimated and underutilised. For example, in a survey of about 150 health partnerships and organisations, we found only 12 who were happy to respond and say that they were led or inclusive of diaspora staff. That's a larger proportion of the response rate, but the response rate was extremely low. And we think that's probably because people are, again, sort of unaware of this issue and or not willing to speak up when they realise that they're perhaps not including the very people that they should be. And this is fundamentally an issue of inclusion within the NHS and more broadly, and of what so often happens, which is that the leadership potential and existing ability of people with different backgrounds is not being recognised and promoted. And this leads to huge opportunity in this regard as well. So we make a number of recommendations in the paper. There is existing work on this. There is support for diaspora professional organisations, for example, particularly for nurses, which is great and could be expanded perhaps to other groups. And then a number of other recommendations for different organisations, health partnerships themselves, us at VET, governments, both in the UK and overseas, and alliances, which are groups of health partnerships and related organisations. And so for us, we decided we need to work to promote diaspora leadership and inclusion in health partnerships and in our work. And so we're now moving to follow that recommendation, which is to create a diversity network, drawing from health partnerships, from NHS trust and board members, from equality and diversity champions and student groups. And I realise this language is contentious, but this is what we have in the paper, that staff's BAME, NHS Trust's BAME networks, it would be great for them to engage with the diversity network and support that engagement. And we're now at a stage of trialling that with 6 trusts and in fact 1 ICS in England at the moment, although this is something we would like to make UK-wide. This is what we're doing, and I'm emphasising at the top that this is a trial, and we are, to a large extent, working it out as we go from a good idea. But overall, our aim is to use this to allow trusts to put greater value on those global connections of their diaspora staff, and to use that to drive inclusivity and also to drive service development. The overall aim being that that has a positive impact on individuals, on the system, and on the patients that they serve. We're doing that by, in those 6 trusts, engaging with trust leaders, diversity groups, whatever they're called locally, and any health partnerships that are within those trusts. And we're just at the very beginning of this at the moment, but looking to initially fact find, so who is doing what and where. And almost literally just mapping what global connections there are, and then making connections between people, so between those trust leaders and those members of the diaspora who have global connections, between those and health partnerships. Ultimately, as I'll go on to, want to expand that outwards to other groups and other trusts. We want the trusts, and will support them in awareness raising within their organisations. So really throwing a light on this work that people are doing, often completely unrecognised and unsupported, and the value of that. And we're encouraging them to find their own ways that suit them locally of facilitating that activity and of raising its profile. That could be anything from holding events to making funding available to better recognising it as CPD so people can have time to do that. The next steps for that, not yet because at a very early stage, but are to expand that to more trusts, to other organisations, so that we're really creating a network. So with Diaspora, nursing and other professional associations, with student groups, etc. We are re-engaging the steering group of experts who guided development of the paper, which includes Marla Rao, who's on the co-chairing with us today, and other people who you will know, including perhaps some who are in the audience, because we're learning as we go, and we need people who are experts and who have their own experiences of these issues to guide us in how to best develop that. We're engaging at high level, so we're engaging with UK government, and I believe Ade Ademi will be with us later on to talk about his work at DHSC and so on. And we also want to engage, so top level of UK Health Service, but also to grassroots level to get NHS staff enthused and driving this in their own organisations, which is partly what this event is about. As we develop, the most important thing for us at THET is to listen, so that we can guide what we're doing based on people's experiences of where we're at the moment and what works for them. And so I'm really looking forward to hearing the rest of our speakers today, and then the discussion to hear what you think about all of this and any ideas you have of how we can strengthen this work and take it forward, and how you can take it forward yourselves. And I just leave you with this quote from Navina Evans, Chief Executive of HEE, who have funded the report that we wrote and also the startup of that network. And I'll just give you a minute to read that, and then I'll stop sharing my screen and we'll move on to Marla. Thank you.
Because the next on the agenda, we have Marla here to share. So I think we've got some slides Kit you'll be sharing on her behalf. Thank you. Marla, it's wonderful to welcome you this afternoon.
Well, thank you so much, Lucy. I mean, first of all, it's such a privilege to be speaking at the Florence Nightingale Foundation Global Health webinar. I really feel honored to be here. Adam, if you'd just show full screen, I'd be most grateful. Adam, or maybe
sorry Marla, it's me and it's gone, but it'll be back in a minute. Hold on.
Okay.
Just for a moment.
Well, while Kit's getting my slides back up, this is a topic very close to my heart, so it may be that one of you is going to have to just ask me to be quiet when my 10 minutes are over, because I really could go on about it for hours. So what I'm speaking about is this whole area of diaspora health workers, how we value their contribution in the UK and globally. Next slide, please, Kit. The key incentive for this discussion is this fabulous report which THET brought together, experts in our midst. And I would really urge everyone who's participating today to read it, because it's not a very long tome, and actually it's a very well written report. And I think the thing for me that made such a difference as an international medical graduate myself is that it brought, and having spent 4 decades in the NHS, I don't know another time or another report which has brought this much needed focus to the completely hitherto unrecognized contribution of diaspora staff. Lucy mentioned it, as did Kit, and I will too. that this has never been recognized before. It was a great privilege to be a member of the steering group, and the report, I think, is a testimony to Thet's commitment, interest, and courage, actually, because, you know, not everyone wants this to be drawn attention to. So I think Thet's been quite bold in saying something needs to be done about this stuff, especially given that, as the report highlights, UK has one of the highest levels of reliance on internationally trained healthcare workers of any OECD country. So my aim today is to share some personal reflections as an international medical graduate and a member of that steering group. Next slide, please, Kit. Now, you know, the background for me, of course, I've had experience of being sidelined or not listened to or something or the other for many decades. But this particular phase I'm in of being very involved in race equality and discrimination and addressing discrimination began when I was invited by Public Health England to review ethnic disparities in well-being and possibly, you know, the possible drivers that could explain it. Now, this was in 2013-14. 16.1% of England's population had an ethnic minority background. It's probably a little higher by now. And our well-being surveys, our Office of National Statistics had begun to do well-being surveys in 2011. And 2011, 2012, 2013, 2014, well-being surveys showed that ethnic minority people across the social gradient reported lower levels of well-being, even after explaining for the usual factors that explain that may offer reasonable explanations of lower levels of well-being, such as housing and employment. And this 2014 report, co-authored with Jackie Stevenson, my co-author, was the first to actually try and explain this. It's easily available on the net. Now, we looked at the wider determinants and the wider environment within which the NHS is located. So when we looked at employment per se across the country, law enforcement and regulation, when we looked at media, education, in all of those experiences and opportunity, we found there were differences which favored the white part of the population. Next slide, please, Kit. And within that, we did a case study of the NHS. And our hypothesis was, is the NHS an exemplar? Is it different as an organization? Does it offer race equality and harmony across the diverse workforce it has? It is highly ethnically diverse, because if it was, our intention was to recommend that all the other organizations, employing organizations, and the organizations that make up our social environment actually emulate what the NHS did. And we picked the NHS as a case study, not just because of its highly ethnically diverse workforce, but let's not forget the fact that its specific focus is on population health and well-being. And 20% of staff are from an ethnic minority background. If you look at doctors, now I apologize here for talking about doctors in particular, but I'm the medical advisor to the Workforce Race Equality Advisory Group. So I have particular knowledge of doctors, but I imagine that much of the experience of nurses is not going to be any different. But 40% of doctors are from an ethnic minority background. Next slide, please, Kit. So what did we find? We found that far from being an exemplar organization, the NHS actually, has the same persistent and glaring ethnic inequalities we found elsewhere in our literature review. And here are some things we found for the medical workforce. And I again mentioned the medical workforce because, interestingly, this group has been researched more than the nursing workforce has. And the British Medical Journal papers are littered with articles over the decades of ethnic inequalities in the workforce. What did we find? that there were inequalities in representation in senior leadership, in employment, and across all measures of career progression, across entire training pathways for junior doctors, and in all specialties, in rewards and recognition, in the reported levels of abuse and harassment, both from patients in the public and peers, in the way professional regulatory authorities such as the General Medical Council treated them. And I know for a fact, since we've started collecting the workforce race equality indicators, that the evidence is very similar for nurses and other professional groups. Next slide, please, Kit. So what was the impact of the report on race equality in the NHS? Some parliamentarians who really had the vision recognized that this report should not just be submitted to Public Health England and possibly, read with interest by a few people and then shelved perhaps, but they launched it in the House of Lords. And as a consequence, it influenced the creation of the Workforce Race Equality Strategy and Advisory Group, because Lord David Pryor, who's recently stepped down as chair of NHS England, happened to attend that launch and was deeply dismayed by what he was hearing for the first time in 2014. Interestingly, as a white privileged man, he was not aware of these differences. He pledged to do something about it, and it also, for us, happily coincided with the arrival of Lord Simon Stevens as Chief Executive of NHS England. He was very sympathetic and concerned also, and these two leaders were key to ensuring that something happened starting in 2015. It was absolutely the right thing to do to focus on the workforce race equality indicators as annual evidence gathering of these inequalities, and to focus on nurses and the wider group of staff who share certain terms and conditions, which all of you will know is referred to as Agenda for Change. The first report had data gaps, but now, goodness me, it's all normalized, the data collection. And we already have 6 years worth of trends that we can look at, not just nationally, but across 231 trusts. And it is only on the back of that that the medical workforce race equality standard and indicators were launched eventually in 2020, 2021, showing similar levels of inequality and variation. Next slide, please, Kit.
Marley, you did ask, so two or 3 minutes left.
Okay. Now, I want to say one thing about international medical graduates. You know, if you hear politicians, they always say it's just short-term recruitment. This is about short-term workforce shortages. But international medical graduates have joined the NHS every year since its launch. They're a large group of doctors now. They constitute 30 to 40% of junior doctor workforce. And if you read Jeremy Hunt's statement yesterday, published in The Guardian, only 37% of doctors starting in the NHS in 2021 obtained their primary medical qualification in the NHS, you know. So 63% joining in 2021 were, you know, people who will be diaspora. Next slide, please, Kit. So, you know, diaspora staff will be contributing to remittances, which Kit talked about. Racism and insecurity it will become a challenge to these people if it isn't already the case, because if they're insecure in their job and they don't feel valued, how would their elders and people in their home countries who depend on these remittances know that this is going to continue to come over the years? Their risk of mortality from COVID, what did that expose in terms of racism and lack of voice? The stress of not being able to go care for family overseas during the pandemic, 2 years when diaspora staff couldn't even go back for funerals. And the pandemic is thought to be a dress rehearsal for climate change in the future. Next slide, please, Kit. The contribution of the diaspora against all of those challenges, clinical contributions that Kit talked about, no opportunity to bring that overseas experience to the NHS. I talk regularly to massive groups of nurses, such as this picture you see up at the top. They are the ones who will come to the NHS to serve it, but do we ever ask them what innovations do they bring? And despite resource constraints in the NHS and the potential for shared learning, we don't ask them what sorts of solutions they may suggest. And we also have evidence that innovation is better trusted if it's developed in the global north. Look at this headline statement from a paper from Imperial College London. We expect that much research from low-income countries has been and will continue to be discounted or ignored. And the engagement with countries of heritage, where are the diaspora academics? Just look at leaders in infectious disease. We're talking about tropical health education trust here. And let's talk about tropical health, not to do with TET, but just tropical medicine. If you look at people who suffer malaria and Ebola and so on, they look a bit like me. If you look at the professors of infectious disease who talk about how to solve these problems around the world, they don't look like me at all. Next slide, please. I think that's the last one. Conclusion. So, we need to support diaspora to achieve their best within the NHS and give back to their countries of heritage. We need to develop this strategy for diaspora engagement that TED talk about in the report. We need to value and welcome these staff. An international medical graduate induction program is being launched for the first time this year since 1948. Give them equal opportunities. Nurses, doctors, and all professional groups need to work together. Value women diaspora in particular, please. We need to do something about them. Allowing diaspora to lead on the how this is to be done. All of us uniting and developing a diversity network to spearhead change. That's what I would end with as a plea for all of us to do something about in the future. Thanks, and sorry if I overran.
Not at all, Marla. Really, really valuable points, and thank you for your presentation. Well, I'm really pleased now to introduce the panel for the panel discussion, which will be chaired by Marla. So thank you very much for joining us. It's with great pleasure that I introduce the panel. I'm very fortunate to work with Rohit, Ariel and Felicia as part of the work that we've been doing at the Florence Nightingale Foundation, supporting the setup and ongoing support to international nursing midwifery associations, which have been set up over the last few years. Some have been in existence for quite some time, and more recently, some have been set up over the last couple of years, where we've been providing small grants to help support internationally recruited nurses and midwives settle into the UK and provide pastoral and professional support. So it's been really wonderful to be part of that piece of work. So thank you. I find it a great pleasure. It's one of the highlights of my role, that's for sure. So Ariel joins us, Ariel Landana. He's the president of the Filipino Nursing Association in the UK. So thank you so much for joining us, Ariel. It's lovely to see you this afternoon. We also equally have Rohit Sagu, who's the director and founder of the British Sikh Association. And finally, but certainly no means least, is Felicia Kwaku, who is the Associate Director of Nursing at King's College London, and also the chair of the Chief Nursing Officer and Chief Midwifery Officer, Black and Ethnic Minority Strategic Advisory Group. So a wealth of experience across all three panel members. And I'll hand across to Marla now to chair the discussions. Thank you.
Thank you so much, Lucy. And again, what an honor to chair this panel with three very distinguished members of the nursing profession. I'm going to begin by asking you to give us some answers to some key questions that I know that participants would like to hear you speak about for say 3 or 4 minutes, and then we'll have a more general discussion. And may I begin with Ariel and ask him, tell us a little bit about your experience of making that transition from working in the Philippines to working in the UK. Were your skills and experience recognized when you first arrived, Ariel? What happened?
Hello, good afternoon. Can you hear me?
Yes, we can.
Hello, good afternoon, and thank you for having me. I'm delighted to be here and for the opportunity to tell my story and share my experiences. Well, it was a baptism of fire. At that time, I felt like a stranger in paradise. I arrived in Oxford in the UK in autumn 2002. It was cold. It was dark. It was depressing. Oxford University Hospitals and NHS Foundation Trust were excellent. The support, very, very good. But the big problem for me at that time was when I come home after work and close the curtain of my bedroom, that's where loneliness and homesickness kick in. And I started talking with my cohorts, and to my surprise, that they feel exactly the same. So what we've done, we came together as a small group of 5 initially, then 12, and now that small group became the Filipino community of Oxfordshire with more than 3,500 members. And the number is increasing every month because we are welcoming several Filipino nurses in Oxford. And in 2020, at the height of COVID-19, I was elected as the president of the Filipino Nurses Association UK. And to date, we have 2,300 official members. And again, that numbers is increasing every day. My degree in nursing and my master's studies from the Philippines were not recognized by the UK universities. But nevertheless, I have gone on to gain my teaching qualification, my Master of Science in Nursing Education, and I'm on my way towards finishing my Doctor of Education here in the United Kingdom. When I left Philippines, I was the officer in charge. Effectively, I was a director of nursing at my trust in my hospital. When I arrived in the UK, my first job was a healthcare assistant. So there was a loss of status. And I effectively started my professional career all over again. But here I am very proud. Thank you.
Oh, Ariel, that's truly inspirational. Thank you so much for sharing that with us. Now, what are your continuing links with the Philippines? And, through your membership association, what are you doing to make things a little easier for newer cohorts coming into the country? Is the association engaging in that? And what are your particular experiences working back with your country of origin, Ariel?
Yes, well, I am now very proud dual citizen, a British and a Filipino citizen. I've been in this country for 20 years, and I have maintained my Philippine nurse's license. And currently, I am an assistant professor of nursing at Central Philippine University, teaching transcultural nursing module to our graduating nursing students. And I am also an associate lecturer at Oxford Brookes University. And I have initiated a discussion between 2 universities about a possible exchange program, starting initially with academics and professors, and hopefully eventually extending this to our nursing students. I firmly believe that both university, the Central Philippine University and Oxford Brookes University, will benefit from this collaboration and learn about different cultures and approaches. And this broader collaboration might help improve our recruitment and retention in university and in the workplace. So I continue my links with friends and families, maintain a regular contact with them. I help build a church in my local village, and I've been invited to speak in different schools in the Philippines, inspiring young people. In terms of my motivation, I believe that it is important to give something back to the Philippines. That country brought me up and educated me and enabled me to enjoy the benefit of living here in the UK. I also believe that the United Kingdom owes a debt of gratitude to the Philippines, which currently provides the UK more than 41,000 registered nurses working in this country. And that number, as I said, will continue to rise. And I know that this is being recognized in the government circles, diplomatic, as well as organizations like Florence Nightingale Foundation. Thank you.
Oh, Ariel, that's absolutely fantastic. Thank you so much for that. It's a brilliant segue to get into the whole issue of healthcare workers' knowledge of different cultures and cultural competence and how that benefits patient care. And I'm going to ask Rohit that question. Rohit, how do you believe diaspora healthcare workers' cultural competence actually benefit patient care? And have you any examples you can offer of how that's worked, please?
Of course, I just want to say thank you to FNF for this platform as well, and thank you to everyone who's organised this event too. In terms of thinking about culture, certainly from the diaspora perspective as well, if we think about culture, it can be defined as many things really. If we think about it, your personal identification, language, customs, beliefs, actions, religion and race. But I think mostly for healthcare professionals, this is about understanding those cultural affiliations that have an impact in terms of the care that we give as well. And it's about understanding and having that awareness of those values and beliefs and different cultures that we tailor our care around, and especially around the needs of our patients as well, and service users that we're caring for. Certainly from my organisation as British Sikh Nurses, what we've done with a lot of the nurses that have joined us in our membership, and we have a membership of around 70 nurses, is we've looked at the community aspect of what we can offer our community. And that's really in terms of just bridging that gap between our nurses and the community, and really, exposing our culture as well at the same time, and educating our culture as well. So one of the things that we've done is we looked at the congregation in Sikh, in Punjabi we call it the Sangat. So we went to the Gurdwara, which is the Sikh temple, and we looked around the congregation, and we saw a lot of health inequalities that were happening within the South Asian community. And we thought about the things that we might want to do around raising awareness of organ donation or stem cell donation, those areas that are, really prominent within the South Asian community. Apparently, we're on figures, we have this, though there are around 1,500 or 1,600 people on the donor register, 1/3 of them are actually from South Asian backgrounds. And this is one of the key things that we highlighted. And it was about bringing our nursing organization to say, okay, I know that we work within the remit of our four walls of our hospitals, but how about, really transitioning what we do within those four walls out into the community that benefit our own. I say that loosely because it benefits everyone, but benefiting our own and specifically targeting those South Asians that we need to. And through our work, what we've done is we've actually increased the stem cell registration to up to 10,000, of which British Sikh Nurses have alone, our nurses and myself, and have registered around 1,500 onto the register. We've also increased the numbers in terms of those who are registered for organ donation, and that is saving up to around 9,000 lives, giving that one life can actually give nine lives as well. So we've really increased the register. We've got acknowledged by the RCN, and I won the leadership award for the RCN last year for it. We also got knowledge by Boris Johnson, which is, I'm going to leave that as a question mark with Boris Johnson, but and with a Points of Light award for the amount of work that we've done. And I will say, from the very beginning of British Sikh Nurses, it was a kind of solo effort, but then, we've had the amalgamation of a lot of nurses joining us as well. But what I want to say in terms of the benefits that our diaspora nurses can make is more so just within the four walls of nursing. I know that we look after our international nurses, but it's about embracing their knowledge and their their technical abilities and their expertise, and saying, what can we actually give within the British community and give back to the British community, and that will make some differences in terms of what they have in their home and their host NHS trust as well.
That's absolutely fantastic, Rohit. This is just so exciting, and I imagine that many other groups and diaspora groups and associations will take away some of those examples and do the same for their groups. So thank you so much for that. But may I ask you about the clinical skills as well? How do we harness these skills that diaspora workers come with, and build that into what they contribute to the NHS? Ariel was talking about, the fact that he came with these very high level skills and they weren't used in the beginning. Is there some way by which we can harness those skills and make better use of them as soon as diaspora workers arrive, do you suppose?
Yeah, I mean, I think Ariel's story was quite touching in terms of what the skills that he's encompassed and the education that he's encompassed as well, that was not recognized. And I think what we really need to do in the very beginning is actually to really acknowledge the skills and education that our international nurses bring to us when they move over, such as PhDs, masters. You know, you'd think in an academic world, I'm actually an academic, so I was in the NHS for 12 years and then I went into 12 years of teaching. So I taught children's nursing. I'm now on a career break doing a PhD. However, what I'd like is, you know, if you know, post my PhD, is that to be recognized universally and globally as well. And I think if you've got an academic qualification like a master's or a PhD, it should be recognized globally and not questioned at all in terms of the expertise that you have as well. I think we need to embrace the digital skills, the utilization of skill mixes within healthcare wards as well, and the roles that they've had previously as well. We've heard from Ariel, he's had a management role, you know, and then to come in from a management role to the NHS and be a band 5, you know, that's, you know, such a disparity in terms of your role. And I think we need to acknowledge that leadership quality that people have within their home countries as well. You know, they may not have the same systems as the NHS, but I'm sure the care that they deliver is at the same level, if not even more higher. And I think we need to embrace that as well and maximize their potential in terms of it. Education is key, as I said, and transferable skills as well. And one of the key things that I'm working with in terms of British Sikh nurses is also talking about the ESOL needs, the English as a second language need, because I think that's really important. That's one of the barriers that really is put up very high when people come over from overseas to England, and it's almost turned around and said, you know, you've got to really think about what you're doing. And I think what we need to really educate is the the terminology that we use, the jargon that we use, the British colloquial sayings that we have as well, the accents, the regional accents that we have, such as Birmingham, Yorkshire, Welsh, you know, even down south in London. Our international nurses will have their own accents, so it's going to be very difficult for understand. And these are the simplistic things that we could really educate our nursing leaders around. And looking at previous roles that they've had, as I said, and most importantly, I think this is really important, and I think Ariel's touched on this as well, and I think a lot of international nurses will touch upon this as well, is treating them with dignity and respect. I think that's utmost out of everything that I have. They come with those qualifications, they come with those expertise, but they also are human beings that need to be treated with dignity and respect.
Thanks, Rohit. And again, you know, that helps me very neatly to go to my next question, which is to do with how do we achieve that integration? I wonder whether I might ask you that, Felicia. What is your experience of offering that kind of support so that international recruits and diaspora who you've recruited perhaps into King's, or indeed what's your message for others recruiting elsewhere into other trusts to provide that level of integration and support? Have you any experience to share with us, please?
Yes, so I think Rohit has kind of highlighted some really useful and really good points. There is that big issue around recognition of prior experience and recognition of qualifications. And in some parts, I think of the north of the country, north of England, they've instigated fast track programs. So staff that come in at a band 5 undergo a series of competency, cultural transformation, skills acquisition, and they are fast tracked to band 6 within a year and a half. So we need to kind of replicate that model across the nation, across the country. We are not good at cataloguing people's previous experience. And it is very individual according to the region and very individual according to the organization. So we've talked a lot about NHS employees, but remember that the diaspora communities, the nurses and midwives, they're across both landscapes in terms of NHS, health and social care, as well as the independent sector. So we shouldn't forget that they transect all of those different healthcare landscapes. So there is something about And there's also something about, there is a big focus on newly arrived nurses. We mustn't also forget the established nurses from the diaspora communities that have actually achieved a level of success. We have examples here, Ariel, Rohit. We also have Oliver on the call from my local organization. So we do have examples of diaspora nurses that actually reached the pinnacle of their success. So we need to showcase them. We need to spread the news around celebration and successes. We also need to ensure that we do a really comprehensive gap analysis. So what does it take for people to reach a band 6, a band 7, a band 8A? How do we identify our bright sparks, our lighting, our bright lights? Who are the people that come that have already published back in Nigeria, in the Philippines, in India, that come with a portfolio of, established academic work and established clinical work? How do we catalogue and have a directory of all of those people? And we don't do that very well. So I think fast track programs they really need to be instigated. I think every organization should have an international officer, whether it's a nurse or a medic, that can really have a clear focus on the diaspora workforce, be able to kind of inform the organization of the talent that they have a really good directory, and be putting people forward for posts, for education and learning opportunities as well.
That's brilliant, Felicia. And I'm going to move on to the flip side, which is diaspora staff wanting to connect back globally. I know that King's has quite an ambitious global health strategy. So I'm going to ask you, what encouragement are you giving to staff in your trust to link back with their countries of origin in relation to health collaboration?
Yeah, that's a really good question, and I have two angles to that. I think we shouldn't forget that we're already doing that. So many of the diaspora organizations across the country are already doing that. A number of us are linking in with our federal ministries of health and sciences back in the original countries. We've got memorandum of understanding with a lot of the healthcare ministries, and we are doing lots of project work, anything from the Sierra Leone communities building and renewing a medical ward to medical missions. So we are actually doing quite a lot already. I think for people wanting to create bridges back with their host countries, in King's, we are in partnership with a hospital, a new build hospital that's going to be built in Abuja in the next couple of years. So we are sharing learning around education programs, clinical pathways, and even issues around the architecture and how we build clinical spaces. So we are heavily engaged within that process as well. I think there is something about making sure that we can make the connections between staff that are really interested in going back home and giving back, and the diaspora communities here. A lot of the work that diaspora communities do, we do it voluntary, we do it in our own time. And so I think one of the key things that's really helped us and supported us is NHS England and the Florence Nightingale Foundation. But we are separate entities, and we need to also make sure that we manage a level of independence. So we are very good as a diaspora organizations in getting communications out. We're good in social media profiles. And I think some of the things that people might be interested in is the giving back. So medical missions are a really good way of staff to give back to their countries. We need to ensure that there's good guidance, because it's not easy when you go and do the medical missions. So we know there's guidance from FET, and I've attended several sessions that FET has run. We've got some good guidance from the unions as well. So that is a really good way to feed back. There are also opportunities for shared education and learning programs. So the Filipino nursing community's done that. We've done that as a Nigerian. We're actually doing it now as a Nigerian Nurses Association. We have a combined education learning program with the United States branch of the Nigerian Nurses Association that have been invited by the Federal Ministry of Health to provide some education and training to staff back home. So we're doing it. We probably need to publicize it a bit wider, make sure that we are realistic. We communicate to staff the realisms of working back home, because when you come here and you're settled, sometimes it's not about forgetting what it's like back home, but they can be wake-up calls for you. So there is something about having those exchanges, making sure that I think one of the key things as well is that organizations really need to know about the diasporas. They should be interested in inviting them in to their organizations so that we've got much more collaboration with the diaspora communities and the organizations. And we saw this during COVID. There was a massive explosion of diaspora communities during COVID. They were there, so a number of them were already there, but we saw new ones emerging. And when the newly arrived nurses come over, it's a real linchpin and a real center of origin for them, a real good pastoral care and support for them. So those are some of the kind of systems and processes we have in place already, Professor Rao.
Well, thank you, Felicia. Now, as we come to the sort of towards the end of this panel discussion, we must ask participants if they've got some questions, but I am very keen to ask you all whether you have an example of something inspirational in terms of a frugal innovation or something that a diaspora member of staff introduced into a ward or into a service that you've been working in, or you yourself might have done. So very quickly, who'd like to go first on that? Is there any example of something somebody has volunteered, which everyone said, wow, that's great? So any examples of that? Ariel, do you want to give us a little story?
Sure. Thank you. I'd like to magnify what Felicia said, that we have already, I think, around 28 or 29 international nursing association diasporas in the United Kingdom, and the number is increasing every day. And I hope that we have employers in this call, or hopefully this will reach out to employers, because NHS employers and social health care employers should recognize and promote the good work of these international diasporas. We in the Filipino Nurses Association UK, these are some of the activities that we have done. We have the welcome meet and greet to our newly arrived Filipino nurses in the UK. And that means so much to them, to reassure that we have a community that will look after them and care for them. The fact that I have been here for 20 years and many Filipinos have been here for more than 20 years, reassure them that this is a wonderful country and there's a great opportunity and future for them. They just need a little bit of help to start with. We provide them with groceries, welcome pack. We provide them with OSCE training, interview skills and leadership workshop for people to navigate with the career progression. And we provide culturally, Filipino sensitive, culturally pastoral care, because that's what they need to start with. I personally, when I was appointed as lead for diabetes in Oxford, there were two teams, the outpatient and the inpatient diabetes specialist nurses team. And that's massive, and it's very costly for public money. So what I've done is straight away, I merged them together. So instead of managing two different teams, then I manage only one very cohesive team. I have a long list, but I give way to other colleagues.
That's absolutely brilliant. I bet it saved millions of pounds, Ariel, just that one thing. Rohit, any example that you could offer from people you've served or yourself?
Sure. Lots of examples in terms of what we've done. So what I want to say thank you to FNF, because they've given us funding in order to do this work, and in order to bring together our nurses and do the work that we're doing. And certainly from British Sikh Nurses, what we've done is not just the stem cell donation, organ donation as well. What we've also really for COVID-19, we went out and supported a lot of our own communities. So some of our nurses, and including myself, actually went out and, went into the Gurdwaras, and we gave, booster injections, and also, the injections that they needed as well. And so those are the things, those pockets of work that we've done are just really recognizable in terms of what they do. And it's going back to what, Felicia said, how do we, we can obviously from a nursing diaspora point of view, go back home and do innovative things as well, but it's actually doing innovative things within this country and supporting this country, having evidence of that within this country and showcasing our work as well at the same time. And I think that's tremendously important that we do that and get recognized for what we give to our own. And it sounds selfish giving to our own, but actually, if you think about it, we're caring for everyone at the same time. But it is that nice, it's the icing on the cake to give to our own.
Thank you very much. A quick example from you, Felicia, something
I
that
really,
might have happened on a ward.
I echo what my colleagues Ariel and Rohit said. I think, and thank you to NHS England and the Florence Nightingale Foundation, because we, as part of a grant, did action learning sets we did it for newly arrived nurses, but we also did it for band 6s and band 7s. And that's really around building networks of leadership, training, and education and support. So we need to remember that, if the nursing workforce and midwifery workforce isn't healthy and well cared for, they can't give and deliver the patient care that they're meant to deliver. So really, we've seen the fruits of action learning sets in terms of cultural adaptation to this country. We've also seen the building up of networks around mentoring. Not many of our host countries have systems around mentoring. So our action learning sets produce some really, really good mentors who are mentoring the newly arrived nurses that are coming here, who are sharing education, learning, and practice around what it means to deliver really good quality and safe care, but also the welfare aspect as well. So remember, in our time now, the issue around health and well-being wasn't so pivotal, but because of the pandemic, it's much more upfront and center. So now we tend to get intelligence much more quicker and speedier. So we heard in the north of England that some of our newly arrived nurses were being housed in caravans in the middle of a field. That's one example. The second example is the issue around contracts and people breaking their contracts and being fined a lot of money to break the contract. So that's a real health and safety issue. And before, people might not have been so confident to raise those issues. Now, because of networks, because of the communication and links with the diaspora communities, we're hearing that much more speedier now. And so we can liaise with our union colleagues and they can put some interventions to help, and we can help and support that as well.
Gosh, that is truly, inspirational. There isn't another word for it in terms of what you're all doing in your own time. That's the other thing. Much of this, it makes me feel this is what our system leaders should be doing for us. But thank heavens that leaders such as yourselves are filling that gap where this isn't being done at all. And we have a collective role in bringing this to their attention and ensuring that there are more resources to help you do this right across all of the trusts, because doing it across 231 trusts isn't a small task. One last question: are you in your associations working with doctors and physiotherapists and everyone? Because I was looking at the Florence Nightingale Foundation website, and it sort of says, something to the effect of, doctors are either looked after or they're looking after themselves, and we need to do something about nurses. You'd be staggered at what a neglected lot the diaspora doctors are. And Felicia is nodding. So I know you will have experience of this on your wards, Felicia. Now, they need help too. And I wonder whether there is some merit in bringing everyone together. And all I want is for you to just say yes or no, and we'll close. So yes. Let me start with Felicia. Yes?
Yes. But to say, just to add, there is already work going on from a multidisciplinary platform. So it's starting to emerge. So absolutely, yes. And although some of us are nursing organizations, some of us are nursing and medical associations, and some of us work closely with the medical counterpart of our Diaspora organization.
Lovely, thanks, Felicia. Yes or no, Rohit? Is the Sikh Nurses Association work? Yeah, yes, that's brilliant to hear.
We work closely with the British Sikh doctors, and we also work with allies as well from Papio.
Wonderful. And Ariel, is that happening with doctors, Filipino doctors?
Absolutely, yes. But unfortunately, there's only very few Filipino doctors working in the NHS. There are so many Filipino doctors in the UK, but they are not working because their qualification is not recognized. I already raised this with our chief executive, and hopefully that we can look at this, because I believe they are wasted resources. So many Filipino doctors who are here in this country.
Right. Thank you very much. I mean, if I were in a room, I'd say, well, can we all join our hands, you know, and because this group absolutely needs our applause. Thank you so much. I think it's time to take participant questions. I don't know if, Lucy, are you planning to do that, or
yeah, I can share. We've got some questions, but yeah, more than happy if anyone would like to ask a question, either raise your actual hand or your virtual hand. It'd be lovely if you could turn your cameras on so that we can see you as well.
Yeah, and I'm also going to take a look at chat, and I imagine.
Yeah, we'll do. I can manage that. So we'll do it together. So I think Joan's been. I imagine Joan Myers may want to say a few words.
There is a question in the chat actually, which we could start with. I'm having to scroll quite a long way up to see it because there's been so much. There's been so much chat, which is
wonderful,
brilliant.
Isn't it? It's absolutely wonderful to see.
It was. I mean, it was specifically for Ariel. I'm not going to necessarily put Ariel on the spot if anyone wants to answer, but it's Chafundo Stubbs has asked. You know, based on what Ariel said about support for nurses, that there are a lot of newly qualified nurses leaving, and is there anything that Ariel has learned or anyone else has learned from their international experience that can be used to support newly qualified nurses in the UK?
Yes, certainly. Thank you. We are working on the principle that nothing should be done for them without them. Nothing should be done for the newly arrived nurses in the UK without them. In other words, it's all about listening with fascination, listening to understand, and listening to work and co-author. So we sometimes feel that we know, the reality is we don't. So what we do in our association is we do the meet and greet virtually. And we listen to them. What are the things that matters to them? And then we start talking about or sharing our experiences about things, you know, like fraud, for example, you know, how to live a life in the UK, how to integrate this cultural adaptation, you know, that feeling of elation, and then all of a sudden a cultural shock. There is no single size that will fit everything. The most important thing is to have that conversation and making everyone feels that they are not alone. And that's the reason why we are here. And I'm very happy to have a conversation offline. I can put my contact details on the chat. It's a very long story to share, but it should be a case-to-case basis. Thank you.
There's quite a few messages in the chat. Does anyone wants to ask a question? Please do raise your hand. Oh, I think Lester. Well, oh, and Gordon as well. Goodness, we're inundated now. Lester, who would you like to ask a question or two on the panel? Over to you.
Well, good morning. For me, I'm Lester. I'm from Nicaragua. Well, I'm preparing me to travel to United Kingdom because I will study my doctoral degree starting in October. But talking about the situation of diaspora, I had experience traveling to a short stance for training in emergency nursing intervention in Czech Republic. But before to travel to this training, I was working in the emergency center of my university, and I was the subdirector of the nursing emergency committee. But when I was there in Czech Republic in the new hospital, trying to acquire new knowledge, all my basics and formal experience was not count, because when I was there, the teams and the direction of the team was like you are the new, you have no knowledge, you have not experience. And it's this situation as a professional, it make you feel like in a lack of knowledge and feeling lonely because you have been working, but when you want to express and share your experience, it's not count because you are like from another context in terms of technology, in context of knowledge and experience. But with the time in my development in this short instance, I can share my experience with the teams, and we can strengthen our abilities because in the context of Nicaragua, we have not enough technology like in Czech Republic, but we have experience improvising the situation for save the life of the patient. And this situation, I think, I'm afraid that will be similar when I arrived to London for my studies in emergency and palliative care, because sometimes the country with more advanced knowledge and technology think that we have not the correctly experience, but sometimes we have not the tools. We have not the tools, but we have the intention, we have the experience how to take the elementary tools that we have in our national context to improve the situation of the patient and maybe to increase the ability of the rest of the team. Thank you. And thank you very much for the amazing work that you are doing, because sometimes when we are foreigner and try to engage to a new teams, we are the best wishes, but in the first days or the first week, all the dreams go down. And thank you for your amazing work, because you are making this instance or the first days of our work better for us. Thank you.
Thank you, Lester. Rohit, I see you nodding quite a bit there.
Yeah, can I just add?
Please do.
What I'm going to say is, it doesn't matter where you're from. I know that we have different nursing diaspora organizations like Nigerian, Jamaican, Caribbean, Filipino, British Sikh nurses, Indian Sikh nurses, but no matter where you're from, so if you are from Nicaragua and you're seeking support and help, come to any one of us. That's what I would actually turn around and say. So we'll all have the same, probably all the same skill set. We'll all have near enough the whole same knowledge and support and expertise that we'll give you as well. So it shouldn't matter whatever corner of the earth that you come from, you can approach any one of us.
Thank you, Rohit. I think our recent celebration event, that was the big resounding message, wasn't it? We are one. It was quite incredible, really, humbling. Thank you, and thank you, Lester. I think it's Gordon next has got a question. Hello, Gordon, welcome.
Thanks very much, Lucy. And can I just start off by saying how hugely inspirational all the presentations have been today. I mean, it's just wonderful just to hear, you know, the work that's been done, and you know, I've got away from this hugely inspired from this session. So thank you very much, everyone. So I guess my question relates to higher education. I'm the assistant head for international in the School of Health and Life Sciences at Glasgow Caledonian University. And I guess I'm thinking about pre-registration students here, but how can we support the students who are starting, who are coming from some of the countries that you've been talking about and others? How can we find out about the diasporal organisations that perhaps we could put them in touch with? And do you think there's any lessons that can be learned from in higher education from the experiences that the documentation that's been related to developed by then, and also the experiences that the panel have had as well?
So Gordon, I guess if I can answer the first part, and then I'll go across the other panel members, but you're more than welcome to get in contact with the foundation, and we can put your students in contact with the INMAs that we work quite closely with, and then the teams within the NHS as well. But I'll pass across to other panel members that have a lot more expertise than myself. So Felicia wanted to add.
Yeah, so Gordon, we have academics in our group, and we have the diaspora groups, and we have the SAG, which is the National CNO group. So we have academics, and a number of the diaspora organisations have pre-registration connections and forums as well. So you've identified something that probably we need to get out in terms of communications. So I think after this meeting, we're happy to leave our details, absolutely. And that is a challenge, And so we focus very much on the newly arrived, but we probably also need to have a direction and steer to the pre-registration students as well, and set up some forums fairly speedily so that we can capture what their needs are. But we work very collaboratively. We have a consortium where all of the organizations meet together and we exchange knowledge and what the needs are for our members. So, you know, we're open. So yeah.
And that very much comes across, Felicia, and I think it'd be great if I could perhaps maybe reach out to you and just so that we can kind of get and access to the knowledge that you all collectively have in that respect.
Sure. I'll hand you back to any of my colleagues. I think Ariel's got a hand up.
Thanks, Felicia. Ariel, over to you.
Thank you. So, Gordon, I am a qualified registered teacher in the UK. That is why I am teaching in the UK university and in the Philippines. And then on my talk earlier, I mentioned that I started the conversation of a potential exchange program because I think this country and countries from the Southeast Asia will benefit. We have completely different system of education, but I think we can learn from each other. So there are also several members of the Filipino Nursing Association who are registered and qualified teacher in this country. So my role is I am the head of the practice development and education. So I dovetail between university life and the practice life, if you like. So I'm the head of several clinical practice educators. So yes, students, we are very, very passionate. We are supporting them because they are our future workforce.
Thank you, Ariel. Over to Rohit. Thank you.
Yeah, thank you. That was a good question. I mean, given that I've spent 12 years in higher education and taught children's nursing at various universities, I think there's two things that spring to mind with pre-reg students. Firstly, that we need to recognize their ESOL needs. Okay, so if they are from another country and they're doing the course as well, we need to recognize their ESOL needs. That's first and foremost. And secondly, what we need to do is really change our curriculum when it comes to revalidation and ensure that we've got cultural awareness threading throughout every single module within the pre-registration course for nurses. And I think that's vital. I had a very good friend of mine, which everyone will know, Beverly Braithwaite. She's written a book published by SAGE about the cultural awareness within pre-registration nursing. And I think that is fundamental that we have that. It should be a fundamental principle that we have as well. I think the third last thing is actually supporting our BAME nurses when they go out into clinical practice as well. They would have gone out into clinical practice. There's some horror stories. We know that, you know, it's structural racism within the NHS as well. So it's really building that wraparound support that we have for those students that go out into placement as well.
Thank you, Rohit. Really good points made there. And Gordon, I hope that was helpful.
On that note, quickly, on that note, sorry, I'm going to leave because I know you've got other engagements. Everyone else, I'm getting recognised at the National BAME Healthcare Awards along with my colleagues. So we've got more. We'll wish you all the very best. I'm sure you'll be winning. We'll be rooting for you, Rohit. Thank you very much for this session. Enjoy. Take care. Take care. Thank you so much. Thank you. Okay, I think we've got a question from, oh, sorry, Marla, over to you.
Lucy, can I just add, do you know, only yesterday, I was at Lancaster University talking about the cultural needs of Chinese students. We're getting, because of the kind of, you know, the global diplomacy and the slight sort of standoff between China and the US, apparently we're getting a huge number of Chinese students here. So just as an extension, since we're talking about pre-registration students, Gordon, one of the interesting things that came out is the need for induction. Here I am trying to launch an induction program for international medical graduates, you know, by the end of June. But it appears that even in universities, there is a need for a proper standardized induction program that's worked out, but asking, you know, previous students what might have made their lives easier when they first arrived, including things like, you know, we register with GPs and that kind of pastoral care, and that you can ask policemen in this, if you're lost in town, you know, unlike some countries they've come from, that came up yesterday, that they would be very wary of going up to police, you know, and law enforcement officers, that you don't need to be in this country, etc., etc. A need for a proper induction to be worked out by all universities for their nursing students. They come in, you know, substantial numbers and in batches, would be enormously helpful. So I think, and maybe if while you develop it, perhaps through FNF sharing it so that the whole country uses it would be enormously, I think, of value in the situation. So thank you, Lucy.
No, thank you, Marla. Thank you so much. We've got a question from, is it Shade or Shade? I don't know if I've said your name correctly. Apologies.
It's Shade. Thank you.
Shade. Oh, sorry. Apologies.
Oh, it's all right. It's okay. Good afternoon, everybody. That's been quite a good conversation, and thank you, Felicia, for the invite. I just wonder, based on the information so far and the presentations and the comments, including the responses, I'm just thinking, is it time for us to look at being politically involved, so that we are looking at being part, as in, you know, the healthcare profession or professionals, being part of the process where policies are set at a political level, so that when we are looking at relationships between the different countries here today, we are actually building on that aspect of it, because it's the councillors, the MPs who actually are at that place. So do we need to be in that forum so that we're influencing from that perspective?
Very good question.
I think Marla can add to this as well, but we are. So to just give you some assurance, I'm on a steering group where at the moment the government is consulting us around how do we enhance global relations, global partnerships, how do we build bridges between low, middle and high income countries. Yesterday, a group of the BAME Consortium met with a few of the ministers to talk about the experiences of nurses and midwives here in this country. So there is dialogue, Shade, going. I think there's a lot more to be done, but we have started the dialogue. For nurses, and I'm sure for doctors, you know, we have our chief nursing officers. So we often get questions and queries that go back to Parliament as well. So there is a dialogue already. I think there is more to be done in terms of impacting policy and legislation. So just watch the space. And I think also there is something about we as people on the ground floor lobbying our local MPs, our local councillors as well.
Great response, Felicia. Great response. And it was wonderful to see actually the meeting yesterday in Parliament. It was great to meet with MPs. So I'd say follow on Twitter. There's quite an active nursing community on Twitter. If you don't do already, you can follow lots of these areas. So Kit, over to you.
So just to follow on, I've put in the chat now, but THET is actually building a group of healthcare workers who are interested in being politically engaged and sharing their voices and opinions on global health, but also, you know, in other areas. And we'd really welcome any Diaspora members who would, healthcare staff who'd like to join that. So I've put the link in the box, and part of that is sort of engaging the MP in your area or the area of your trust to be aware of these issues. So that could be a good starting point for some people. And it's not my job to do the segue, but I think it, shall I, Lucy? Because it perfectly brings us on. It perfectly brings us on to
There was another question, but I think there's going to be lots of questions, which is wonderful to see the debate. But I'll let you do the segue, Kit. Go for it.
It is 20 past, so in the interest of finishing on time, we have Ade, who I'm sure will introduce his role, but works within the DHSC, and I don't know exactly what he's going to talk to us about, but he is doing a lot of work there in terms of engaging Diaspora in UK global health policy, etc. So thank you very much for joining, Ade, and fire away.
Thank you, Kit. And yeah, to echo lots of comments and things made by everyone here, it's a real pleasure to be here. By way of introduction, my name is Ade Adeyemi. As Kit said, I work in the International Directorate of the Department of Health and Social Care. I have a background in the NHS for many years, lastly at NHS England, but now at DHSC, and a background working with lots of diaspora groups, both in the UK and with the African Union Centre for Disease Control in Addis Ababa. And for my sins as well, also doing research, my PhD at King's College London in global health. So a topic really close to my heart. and within the Department of Health in the International Directorate, working on our bilateral relationships. So, foreign affairs, the way that we interact with other countries, particularly in the Americas region, so North and South America and some part of Australasia. We do have other colleagues and other people in the government that, form relationships with other parts, other countries. As someone who was born in Nigeria and came to the UK when I was very small, dual identity crises and all the issues we've spoken about, identity and, diaspora healthcare clinicians, wanting to move from another country and working in the National Health Service is something I understand, directly. Lots of my family and friends are in similar positions to what's been mentioned here. And I suppose it is, quite frankly speaking, quite an embryonic area of policy for the Department of Health. So there isn't a lot I can formally share. Also, I don't think I'm at that level where I can normally set policy just yet. So I'm going to be quite guarded with what I'm saying, but that's only because it is still something we're working towards. Obviously, as a diaspora, I am passionate about this personally and trying to make as much headroom as possible. Some of you would have been in some of our private listening events that we've held, where we want to gather that evidence, and THET has also been alongside with us in each of those events because they already have that evidence base. And I hope they wouldn't mind me sharing as well, but we're having some conversations with senior ministers about this topic, and again they're part and parcel of it. So at the very highest level in the department, it is being understood. Marla was also in one of the conversations with the previous minister before, and I think the other one as well, but I wasn't around for that. But anyway, details aside, to say that this issue is being heard and understood, and for all the reasons that we understand it to be, that is why it wants to be embraced at DHSC, and we do something more formally with it, not only for the health and well-being of staff within the country, but also for the links and the value add and all the other stuff that we've spoken about, that it helps with the UK, health relationships with other ministries of health, that Diaspora bring to the table and can add. Everyone has said everything about why it is a good thing to do. And now it's just that kind of detailed bureaucratic step of, okay, how does it formally look like and how does it formally sit within the department? How do we formally recognize? How do we take what we're hearing from diaspora organizations, health alliances, etc., formalize those relationships, work it into the, ways of working, the natural go-to organizations for the department. And that will take some time. But again, the conversations that we're having with ministers and the way they understand the benefits, both domestically and internationally, suggests that hopefully it won't be too long before we see some really, paradigm shifting approaches to this. And I don't want to put a time frame on it, but I've said it and I feel like committing myself to it. But within the next year or so, or even sooner, I think we'll see some really formal things, and I definitely would love to see it. So I'm holding myself to account on that. But I probably will stop there because I know we're running out of time, and I'd love to take any questions if people did have any they wanted to throw out.
We've got a couple of minutes for questions, maybe 1 or 2 questions for Addy. So you can pop them in the chat box or raise your hand, or alternatively we can put you in contact if you want to catch up with Addy later, if that's okay. Addy, if that's yeah, great.
To say something?
Oh, hi, Joan, please do. Welcome. Joan, very proud to have Joan with us. Joan is one of our trustees at the foundation. Joan, over to you. Thank you so much for joining us.
Thank you. It's been really inspirational listening to everyone and the fantastic experiences that everyone has gone through and been so stalwart and resilient and actually transferring it onto others, and they're doing phenomenal work. And as I was listening to some of the things that Ariel, Rohit and others have said, and I'm putting it in the chat, when's the conference coming up where they can showcase all the great work they're doing in over here and also overseas, and also demonstrating the transferable skills that has been dumped down in some cases, but which I had an example of somebody came over as a band 4 and then became a band 5, but they're now a band 9. But when they were in that position as a band 4 and CQC came in, the organization was given a very low reading. Actually, the only good thing they had to say was this person had written care plans for her patients that nobody else was doing. And the CQC actually said, why aren't you doing this? And that's when they realized that she had something to offer. And I think we come in with all these skills and competencies, and the NHS is basically cutting off their nose to spite their face sometimes by not actually allowing people to utilize the skills that they've got. But what I wanted to say regarding what Ade said, I remember Lord Nigel Crisp was asked by the then government to go over to Africa and see what we can do over here to help the people in Africa. And he came back and he wrote that book, The World Turned Upside Down, in which he recognized that the people overseas have got so much to teach and train and support us. And they could teach us, and it's a two-way process. It's not us doing to them, it's what we can both do to support and help each other. And one of the examples he said was in Africa, they haven't got all the machinery like blood pressure machines and all the rest of it that we have in the UK. They just look at a patient and they can actually assess and diagnose a patient just by looking at a patient. And we can learn so much of those things from Africa, and that's just one example. There's so much we can actually cross-fertilize. And my ambition, if I was the Chief Nursing Officer of England or the Chief Exec of NHS England, I would ask every NHS organisation to partner with an organisation, an NHS trust or a hospital in all of the countries of the world. Every NHS organisation should partner with at least one, and I know that some of them are doing it, partner with another organisation overseas so we can learn from each other, and then there wouldn't be so much discrimination and bad behaviour going on, because we'll be learning on the spot and we'll be really valuing each other and what we have to offer. So thank you.
Joan, thank you so much. Always you always share such words of wisdom. Thank you. Glad you could join us. Unfortunately, I've got the awful task of wrapping up, so we're running out of time. But God, what an afternoon. Thank you so much for joining us. I just wanted to, I had three key takeaways I wanted to share with you really. But it's absolutely critical that we recognise the skills and expertise of prior experience of not only nurses and midwives, but the broader MDT coming to this country, and how we can share those transferable skills, that wonderful symbiosis that could go on that Joan just spoke about. I really like Rohit's point about treat everybody with dignity and respect. That sounds so simple, but actually is so vital and important that we should be treating them with dignity and respect, and really should be sharing celebrations and successes and showcasing, and raising the profile of our diaspora healthcare workers as well, which I did pop in the chat that our next webinar in this series is showcasing the work of our INMAs that I was talking about earlier, and also more broadly. But I love the idea of a global conference, and I think Ben Sims has popped something in the chat around the DEC conference too, so please do keep your eyes out for that. I think the three words that I wanted to sum up this afternoon was that I'm humbled, inspired and privileged to be part of this webinar this afternoon. Thank you so much. It's been a pleasure to partner with you, Kit, and with that, and look forward to a lot more collaboration between our organisations. So thank you very much. Just to remind you, it is recorded, so you can share it with your colleagues. Please share it far and wide. Please make sure you take back the wonderful report from THET, Experts and Unmissed, and share it broadly with your colleagues across your trust. Let's really raise the profile. This is just the beginning of something quite amazing, I think. So thank you all. Enjoy the rest of your days, and we're right on time. Take care. Thank you.